that time. Now, what is the meaning of peripheral neuropathy first? What do you understand by that term? Yes, I want some answer here. What is the meaning?
Loss of sensation in the periphery, sir.
Okay, okay, yes. Anybody else?
The damage of peripheral nerves, sir.
Damage of peripheral nerves. Both of those answers are correct. So let me clarify this. Peripheral nerve is a mixture of motor nerve, sensory nerve, and autonomic nerve. So this topic, okay, will be involving these three components: damage to the motor nerve, damage to the sensory nerve, and damage to the autonomic nerve. Different types of nerves are there in our system. Some are purely sensory nerve, some are purely motor, some are mixed nerve. So according to the involvement, the clinical feature will be there. That's the first thing. And the second, spinal nerves and cranial nerves both are peripheral nerves. Okay, except cranial nerve 1 and 2, all other cranial nerves are considered a peripheral nerves. Now see here. So let's start with a little bit of anatomical, meaning. These are the types of peripheral nerves we have: cranial nerve, spinal nerve, and the autonomic nerve. Except cranial nerve 1 and 2, all other cranial nerves are considered peripheral nerves. Cranial nerve 1 and 2 are considered the direct extension of the brain. That's why they are not considered as a peripheral nerve. Okay, that's the meaning. Now we have 12 pairs of the cranial nerve, we have 31 pairs of the spinal nerve, and we have got autonomic nerves as the sympathetic and parasympathetic neurons. Now, just now, you have gone through this important part of this neurology, how a spinal nerve is formed. So this is a cross section of the spinal cord. You can clearly see the outer part is the white matter, the inner part is the gray matter. The posterior aspect belongs to the sensory system, anterior aspect belongs to the motor one. Okay, especially if we talk about the gray matter. Now, this is the origin of the ventral root. Backside is the origin of the dorsal root. They combine together to form a spinal nerve. And dorsal root ganglion is only concerned about the sensory system. After a spinal nerve is formed, it will quickly divide into ventral ramus and the dorsal ramus. And there are rami communicantes also there. This rami communicantes is the connection between the spinal nerve and the sympathetic ganglion. See this is sympathetic chain ganglion there. So there is a connection between the spinal nerve and then the sympathetic ganglion. This is done by rami communicantes. So this is in short, okay, the anatomy of the spinal nerve, which I'm sure every student know by now. With this, let's enter into our topic. Peripheral neuropathy is a term applied to any condition affecting the peripheral nerve function. There are so many causes, so many. So any of those diseases or causes which leads to peripheral nerve dysfunction is known as peripheral neuropathy. The disorder can affect the peripheral nerve soma. Soma means cell body, which are referred to as neuronopathy, or peripheral nerve fiber, which are known as neuropathy. But peripheral neuropathy is a generalized term, in many textbooks. When this term is, written there, both of the terminology come inside it. Both neuronopathy or neuropathy, both are included under peripheral neuropathy. Most peripheral nerves are mixed nerves. They are mixed nerve and they have sensory, motor, and autonomic functions together. When they reach to the peripheral, organ or the effector organ, we should say, they are already carrying the autonomic nerve, the motor nerve, and the sensory nerve. That's why they are called mixed. The pure form of sensory or motor neuropathy occurs when the soma or anterior horn cells are selectively involved. And one of the very important example students know, that is poliomyelitis disease. The polio virus specifically affect the anterior horn cell. So there are no sensory involvement in polio disease. Okay, and if only dorsal root ganglion is affected, then we have pure sensory type of problem. One of the important example I can give regarding the dorsal root ganglion lesion or involvement is herpes virus. This herpes virus specifically, lodges itself in the different type of sensory ganglia in our body. Okay, let's move on. Let's see here. Now, another important part of this lecture is the causes of peripheral neuropathy. Now, see there. There is a very famous or common mnemonic, okay, which we always relate or correlate with the causes of peripheral neuropathy. This is just to make the things easier for you. Okay, you don't need to follow this way. You can build your own way to remember these things actually. So see there, DANG therapist. So we use this initial letter, okay, as some of the causes of the peripheral neuropathy. Like D stands for diabetes here. Diabetes is one of the commonest cause of peripheral neuropathy these days, because the incidence of diabetes is increasing all the time all over the world, especially the type 2 diabetes. And one of the long-term complication of diabetes mellitus is peripheral neuropathy. A stands for alcohol. Alcohol is a toxin, and that toxin can badly damage the nerve. So peripheral neuropathy occur with alcohol consumption. Nutritional deficiency, especially vitamin B12. Just now you talked a little bit about that. Subacute combined degeneration of the spinal cord occur in vitamin B12 deficiency. Guillain-Barré syndrome, G. Okay, in detail we have already talked about this. This is a type of autoimmune disease where the autoantibodies are targeted against the myelin sheath of peripheral nervous system. T stands for toxic neuropathy, and that can be caused by heavy metals or the drugs, or it may also be caused by some metabolic disorder like hypothyroidism, liver disease, or kidney disease. So lead is one of the important substances which can cause peripheral neuropathy. Lead, it's an example of heavy metal. Can you tell me one of the drug which can lead to peripheral neuropathy? Which drug? Anybody?
Isoniazid.
Excellent.
Isoniazid.
Very good. I am waiting for that answer actually.
Isoniazid.
Excellent. This is a type of anti-tubercular drug, isoniazid, which can cause peripheral neuropathy. And to treat that peripheral neuropathy, you need to give one vitamin. What is that? Which vitamin is provided?
Vitamin B12, B6,
Pyridoxine.
pyridoxine.
Excellent answer. Excellent answer. This is pyridoxine or vitamin B6. Pyridoxine or vitamin B6. Okay, it is provided. Now another cause of peripheral neuropathy. Okay, we use H and E here together, is a hereditary neuropathy. We also call them hereditary motor sensory neuropathy. Hereditary motor sensory neuropathy, and the most common types here are hereditary motor sensory neuropathy 1 and 2, and they are also known as Charcot-Marie-Tooth disease. Commonly used question in the exam, Charcot-Marie-Tooth disease. Now this of course run in the family, that's why they are known as hereditary conditions. They are multiple genes are involved there, and they run in the family. In these disorders, okay, both motor as well as sensory problems will be seen in the patient. So there may be atrophy of the muscle, okay, there may be weakness of the muscle, there may be loss of the sensation, there may be some deformity development. All those things would be there. When we move in the later half of this important lecture, then some important findings are again highlighted there. Okay, how to take the history how to physically examine these patients. Some features of Charcot-Marie Tooth disease will again come back there. Now, R stands for recurrent acute intermittent porphyria and chronic inflammatory demyelinating polyneuropathy. So this intermittent porphyria is a disorder of the heme metabolism. Heme is a part of hemoglobin, and hemoglobin is present inside the RBC. So you can correlate like that. So porphyria can also damage the peripheral nerve. A stands for amyloidosis. This is an abnormal type of protein which is synthesized by liver in response to any chronic infection or inflammation, and that protein can be deposited in different organ or the system. It is important cause of peripheral neuropathy. P, other porphyria apart from intermittent porphyria, something known as porphyria cutanea tarda, okay, and some type of chronic porphyria as well. I stands for inflammatory lesions or conditions like Lyme disease, HIV, subconnective tissue disorder or vasculitis, and even paraproteinemia. These all cause peripheral neuropathy by inflammation. Now, what is the causative agent of Lyme disease?
Borrelia burgdorferi.
Very good answer. Very good answer. Borrelia burgdorferi. Borrelia burgdorferi is the causative agent. Okay, it's a Borrelia organism. Then paraproteinemia. Give me one example of this. Paraproteinemia. In which disease it is seen? Anybody know?
Liver disease.
Okay, see here. So this paraprotein is the abnormal type of protein, and one of the common example we have to think here is multiple myeloma. Multiple myeloma. Okay, or Waldenstrom macroglobulinemia is another example where IgM is produced, and in multiple myeloma IgG type of abnormal antibody is formed. There is a light chain production there, and there are so many other clinical features of multiple myeloma, but it can damage the peripheral nerves. Systemic diseases, any chronic diseases, okay, of the system may involve, again, connective tissue disorders comes here as the example, and tumor like paraneoplastic neuropathy as a result of paraneoplastic syndrome may be considered. So different causes are there. Now let's move further. Let's talk about some of the important features of peripheral neuropathy. What are the sensory symptoms? What are the motor symptoms? And what are the autonomic symptoms? Regarding the sensory symptoms, the common symptoms include pins and needles, also known as paresthesia in the extremities, especially the hands and feet, they are affected. Patient may feel numb there, or sometimes patient may feel hyperesthesia also. Hyperesthesia means increase awareness of the sensation. If we touch gently there, patient feels increased awareness of the touch, and it is a bit of unpleasant type of sensation. This is known as hyperesthesia. Patient may feel about pain or a burning feeling or sensation there, and then a decrease or insensitivity to cold and warm. These again are the result of damage of sensory neurons. One very important point in the history taking is where they start, from where it started. They usually start in the distal part of the limbs, both in the lower extremity and the upper extremity, and they can gradually progress to the upper part of the limbs. This is a very typical of peripheral neuropathy. At the onset, they can be asymptomatic or focal or symmetric. Later on, okay, they can become intermittent or slowly progressive also. It depends on the different types of peripheral neuropathy or different causes actually. So don't generalize these things. Sometimes they are symmetric, sometimes they are focal, sometimes they are generalized also. Some patients may even present with imbalance. If dorsal column tract is mainly affected than spinothalamic tract, then the problem of imbalance may be there, because we all know the sensation of proprioception, sensation of balance, these are the function of dorsal column tract. Okay, so let's move on. What are the motor symptoms then? So motor symptoms are the weakness. So the patient may complain of weakness in a particular part of the body. See this, okay, weakness, cramping of the muscle, and even the fasciculation, because these are the part of lower motor neuron lesions. So fasciculation is important feature there. They mainly started in the distal group of muscles and progress proximally, similar to the sensory involvement here. The extensor muscles are more greatly affected than the flexors. It's difficult to give explanation here, but it is a common type of involvement. Onset could be symmetric or asymmetric. We cannot generalize the things. Some of the conditions may be symmetric or some asymmetric. A good example is a Guillain-Barré syndrome. This is the symmetric type of involvement, whereas poliomyelitis is asymmetric type of involvement. Now, when you are taking history, how do you know whether it is proximal muscle involvement or distal muscle involvement? You need to correlate these with some important questions there. Like, okay, if the patient cannot unbutton a shirt, if the patient cannot turn the key, if the patient cannot comb the hair, okay, all of these are important points. Turning the key, unbuttoning a shirt are the feature of distal group of muscles, whereas combing the hair is the feature of proximal group of muscles. Remember, we need to raise our upper limb, okay, and take that upper limb to the head area, then only we can comb the hair. So proximal group of muscles play a big role when we lift our upper limb upward. So this type of questions are really important when we take the history. Now, what are the autonomic symptoms then? What happens to the patient? How we take the history? See this, the autonomic symptoms which are seen in case of peripheral neuropathy may include orthostatic hypotension, dizziness, dryness of the eyes or mouth, abnormal sweat pattern, persistent diarrhea, vomiting, and even impotence. So these all are the functions of autonomic nervous system. So if they are involved, then there may be abnormality of these things. I'm sure many of these things you already know. Some are features of sympathetic nervous system involvement. Some are the features of parasympathetic nervous system involvement. Now, as a doctor, okay, or as a medical student, we are going to examine these patients, isn't it? So what are the important signs you will get there? Okay, the concept will be very clear now, because most of the things we already discussed in the symptom part. Now, pay attention here. Okay, regarding the sensory sign, there is decrease or absent sensory modalities like pain, touch, vibration, joint position, stereognosis, 2-point discrimination. All these are either decreased or absent, and there is a positive Romberg sign. So I hope you still have not forgotten what is Romberg sign. So if Romberg sign is positive or present in the patient, what does that signify? Where is the lesion there? Anyone?
Dorsal column.
Dorsal column tract. Dorsal column tract lesion. Column.
Excellent.
Dorsal
All the
column
students
tract.
are answering the same thing. Very good. This is a feature of dorsal column tract lesion. Don't answer, this is a feature of cerebellar lesion. Okay, that's the wrong answer. It is a feature of dorsal column tract lesion. Excellent. That's why it may be present in the patient, because we are talking about sensory sign of peripheral neuropathy. The typical sensory deficit is known as globe and stocking type of distribution. Very commonly used term in the neurology. Globe and stocking distribution. This means the distal part of the limbs are affected, means they lose the sensation there. The hallmark point of peripheral neuropathy. The sensory deficit, however, could be in the distribution of one nerve, and when that happens, we use the term mononeuropathy, or multiple nerves, we use the term polyneuropathy or mononeuropathy multiplex. Now, mononeuropathy multiplex means involvement of a nerve in a patchy way. For example, in the lower limb, common peroneal nerve may be affected. In the upper limb, median nerve may be affected. And in the head and neck area, great auricular nerve may be affected. So mononeuropathy multiplex. Some of the disease may specifically involve this type of nerves. Polyneuropathy is a more generalized type of involvement. Now, what about the motor sign and the autonomic sign? Okay, so let's go through them. The motor signs include muscle weakness, and we all know how to examine these muscles. Okay, we examine for the power of the muscles now. Power, and power of the muscles is judged or examined by giving different, force or the power, and asking the patient to act against that force of the power, and we judge what is the grade of the muscle weakness. In this condition, the distal muscles are more weaker, okay, than the proximal. Extensors are more weaker than the flexors. So these are the important features. In the later stages, there is atrophy of the muscles as well, because this is a type of lower motor neuron type of lesion, so muscle atrophy will be there. There is decrease or absence of the reflexes, and we use the term hyporeflexia or areflexia for this condition. There is decreased muscle tone, okay, this is hypotonia or atonia or flaccidity. There is fasciculation or twitching of the muscle fiber, and occasionally there may be tremor as well. But tremor is not an important feature of this peripheral neuropathy. So please analyze these. All of these are important feature of lower motor neuron lesion. So if a student doesn't know still what is the feature of lower motor neuron lesion, okay, please follow these. These are the features. The last part is autonomic signs. So orthostatic hypotension is there, and we need to prove this in the patient. It's very easy. Take the blood pressure when the patient is lying down comfortably on the bed. Ask the patient to stand up and take the blood pressure again. If there is a difference by more than 10 millimeter of mercury, that is known as orthostatic hypotension. If more than 20 millimeter difference, patient may feel dizzy. Absence of heart rate variability to standing is another important feature of autonomic nervous system involvement. The meaning is, when we stand, our heart rate should be slightly higher than when we lie down. If that doesn't happen, then something wrong with the sympathetic nervous system. Sluggish pupillary reaction to light, Horner syndrome, and dry mouth or eyes are some other important features of autonomic nervous system involvement. We all know what is the effect of light on the pupil. It should constrict, it should become smaller. If that doesn't happen, probably, okay, the parasympathetic nervous system is having problem. We already talked about Horner syndrome in the last class. It's a combination of meiosis and hydrosis, okay, in ophthalmos and ptosis. Dry mouth or eyes are other important features of sympathetic nervous system involvement. Okay, dry mouth is more of parasympathetic, I should say, but if it is occurring on the forehead, then we relate the sympathetic nervous system there. When we examine these patients, what we get, what are the signs? The following manifestations have particular diagnostic importance regarding peripheral neuropathy. They are palpable and hypertrophic nerve
we usually palpate great auricular nerve, common peroneal nerve, and the ulnar nerve. Okay. Please mute yourself, guys. So we usually palpate great auricular nerve and common peroneal nerve as well as ulnar nerve. These three are very commonly examined in clinical practice. And they are palpable and hypertrophic in case of hereditary neuropathy. One of the important example is Charcot-Marie-Tooth disease. Amyloid neuropathy means deposition of amyloid substance in the nerve, and very important in the developing world is leprosy. Leprosy is an infectious disease caused by Mycobacterium lepra. Okay, so these are some of the conditions where nerve is palpable. Don't forget that, very important questions from the exam point of view. If we examine the skin, okay, we can get some rashes or skin lesion like, okay, the conditions are porphyria, okay, porphyria, sarcoidosis, okay, sarcoidosis, lupus. This lupus is lupus erythematosus or SLE, and even diabetic skin ulceration, because all of these are damaging the nerves. Okay, all of these are damaging the nerves. Okay. Now, examine the nail bed for Mees line. These Mees line are seen in arsenic poisoning. Arsenic is a type of heavy metal, and that arsenic may be deposited in the nail bed, causing Mees line. I have, collected one picture from the internet, and I'll share you that picture a bit later. Deformities like pes cavus and kyphoscoliosis are seen in hereditary neuropathy. Hereditary neuropathy. Again, Charcot-Marie-Tooth disease is the common example. Now, pes cavus means the foot, okay, the sole of the foot is arching, okay, above or arching up. It is forming like a cave. That's why it is called as pes cavus. Hypertrophic muscles can be seen in hereditary neuropathy. More commonly, atrophy of the muscle is seen, but in some of the hereditary neuropathy, even hypertrophic of the muscle can occur. And amyloidosis, quite naturally, because there is an infiltration of amyloid-like substance there. Okay, so the muscle will look bigger. And enlargement of the tongue is seen in amyloidosis. So what we are talking here, these are some of the signs which will help us in the diagnosis of peripheral neuropathy cause. Now see here, please focus on a slide. These are called Mees line. This is a nail bed, okay, and these are the Mees line which are seen in arsenic poisoning. Arsenic is a type of metal which may be present in our earth, even in the water in some of the part of the world. Now, this is called pes cavus. Now, look at the sole here. Okay, look at the sole of the foot. It is arching up. Okay, so this is called as pes cavus. And sometimes in Charcot-Marie-Tooth disease or hereditary neuropathy, flat foot is also seen. Not always pes cavus. Sometimes pes planus we say, or flat foot also can be seen. Now, how to evaluate or how to investigate a case of neuropathy? These are some of the important tests. Nerve conduction study and needle electromyography are usually done because this is a case of peripheral neuropathy. Now, this will tell us whether that nerve is damaged or not. It will not give us the diagnosis of the etiology. Remember that. It will just diagnose whether peripheral nerve is intact or damaged. That's it. Routine or initial evaluations which are done in case of peripheral neuropathy are CBC, ESR, biochemistry profile, that means liver function test and renal function test, and serum protein electrophoresis and vitamin B12 level. These are done in all cases with neuropathy. That's why they are called routine or initial evaluation. Okay, they may pinpoint towards certain important features of peripheral neuropathy, like complete blood count is abnormal in some infectious condition. ESR is high in inflammatory or infectious condition again. In liver functions, and in case of renal failure, chronic renal failure, there is a condition of peripheral neuropathy. We studied that before. And serum protein electrophoresis is a test which can show us some abnormal proteins, okay, in the serum. One of the important example here is multiple myeloma, which can damage the nerves, as well as vitamin B12 level, because deficiency of vitamin B12 causes which disease? Which disease is caused by?
Subacute combined degeneration.
Combined degeneration of spinal cord.
Subacute combined degeneration.
Very good, good, very good answer. Subacute combined degeneration of spinal cord. It is called subacute combined degeneration of spinal cord, where both motor as well as sensory, okay, tracts are affected, both. That's why it is called combined degeneration. Now, some of the selective workups, we do these in a particular condition only, okay? Like in acute mononeuropathy, we go for a routine workup, which we have just explained. But in case of acute generalized polyneuropathy, means most of the nerves in our bodies are affected, and it is a type of overall affection or symmetrical type of affection or patchy involvement here and there, then we go for this type of test. In case of GVS, we go for nerve conduction study, which is a routine actually. After that, we go for spinal tap. Okay, spinal tap means CSF evaluation. CSF evaluation. Now, when we do CSF evaluation, you all know what finding we get in GVS. What is the finding?
Albuminocytological dissociation. Albuminocytological dissociation.
Exactly. Albuminocytological dissociation. Albuminocytological dissociation. That means it shows elevated protein without increase in cell. That is known as albuminocytological dissociation. Don't forget that. In case of heavy metal intoxication like lead, okay, like arsenic, like mercury and all these things, we go for urine and serum, lead, mercury and arsenic level. For arsenic, rather than serum and urine examination, we go for hair analysis and nail analysis, because arsenic is deposited in those special areas. Porphyria, example is acute intermittent porphyria. Okay, this is a disorder of heme metabolism. In this condition, there is decreased porphobilinosin deaminase level of red blood cells. So we can go for that particular test and diagnose it. If HIV is suspected, you go for HIV investigation. That is done by ELISA, Western blot, and you have to evaluate or analyze the cerebral spinal fluid also. Okay, and then you can go for CD4 count also. You can even go for PCR. So many different things you can list here. Regarding the Lyme disease, which is caused by Borrelia burgdorferi, you can go for, again, CSF analysis and antibody against that particular organism. So these are the specific investigation which are only done in suspected cases, not in all. Now, if mononeuropathy multiplex is suspected, then we go for this type of investigation. Now, what do you mean by mononeuropathy multiplex? Now, see here, this means involvement of the nerve in more than two important areas, and those areas are distinct from each other, means they are apart from each other. So two important nerves should be involved, okay, and that is usually asymmetrical here and there. This is known as mononeuropathy multiplex. So we go for ESR, okay, rheumatoid arthritis factor, and anti-nuclear antibody. Now, you all know these tests are very importantly done in case of connective tissue disorder diagnosis. ESR is a non-specific test which is elevated in most of those conditions. RA factor is present in seropositive cases of rheumatoid arthritis. It is called seropositive case. And anti-nuclear antibody is very important test in case of SLE. This is sensitive test for SLE. CRP is another non-specific test. Okay, angiotensin converting enzyme level. Now, can you tell me this enzyme is elevated in which of the disease, and that disease has a connection with peripheral neuropathy? Which one?
Sarcoidosis.
Excellent. Okay, excellent answer. That is sarcoidosis. Don't forget it. This is an important MCQ question for you in the exam. So this is sarcoidosis, where this angiotensin converting enzyme level is elevated because those sarcoid tissue, they are going to produce this particular enzyme. This is utilized as a diagnostic point there. Chest X-ray, so many causes you can list here. Okay, again, the important one is sarcoidosis. In sarcoidosis, there are so many findings in our chest. One of the important points you should never forget is bilateral hilar lymphadenopathy. Bilateral hilar lymphadenopathy. Okay, and in severe cases, then there will be fibrosis of the lung as well. Go for muscle or nerve biopsy, and in this situation we can go for superficial peroneal, okay, nerve and peroneus brevis muscle. Okay, superficial peroneal nerve and peroneus brevis muscle. Or you can also go for sural nerve. Sural nerve is also commonly sacrificed for the purpose of nerve biopsy. Skin and nerve biopsy are taken in case of leprosy. Okay, leprosy is a disease which you will talk in dermatology. It's a very important disease there. But leprosy mainly affects the skin and the nerves. For the hereditary neuropathy, you have to go for DNA analysis, okay, because these are associated with hereditary condition. So Charcot-Marie-Tooth disease is a hereditary neuropathy, and you have to assess for CMT1A gene there. If it is present, probably the disease is diagnosed. Sural nerve biopsy can also be done. Regarding the entrapment neuropathy, okay, for example, carpal tunnel syndrome, we have studied that in orthopedics recently. You can go for the causes which leads to carpal tunnel syndrome. And those causes, if I want to quickly list here, few of the important one are diabetes mellitus is one of them, hypothyroidism is another one, acromegaly is another one, and rheumatoid arthritis is another one. Okay, so remember these 3 or 4 causes, and some local causes are almost always there, like Colles fracture, any wrist injury which can lead to excessive reaction there. They are also the common cause of carpal tunnel syndrome. And profession of the person. Okay, don't forget that. If the person uses a laptop or computer, okay, all the time, and when they use it, if the ventral aspect of the wrist, okay, is lying against the edge of the desk, then that is one of the very common cause of carpal tunnel syndrome. Now let's come to the point here. We have to go for routine workup, of course, then go for thyroid function test to diagnose hypothyroidism. And in case of hypothyroidism, what happens to the TSH level? If it is a primary hypothyroidism, what happens to TSH level?
Increase.
Elevated.
It will increase.
Absolutely. T4 is decrease and TSH is increase if it is a primary hypothyroidism. Very good. Okay, so we have discussed that before, but don't worry, when we enter into the endocrinology, that is one of the big topic called thyroid gland disorder. We'll again highlight it there. An X-ray of that particular area or wrist should be done all the time. Okay, let's move on. Now, finally, what treatment should we provide for a case of peripheral neuropathy? Now, treatment should be done only after the proper diagnosis. Otherwise, it's just like, throwing the stone in a darker, situation, isn't it? We are not sure whether it will work or not. So specific therapy regarding the few conditions are highlighted here. Prednisolone or corticosteroid and other immunosuppressive drug are specifically given for vasculitic neuropathy or connective tissue disorder which are involved in those. plasma exchange and intravenous immunoglobulin or IVIG is given in this situation like Guillain-Barré syndrome. Okay, CIDP is chronic inflammatory demyelinating polyneuropathy, chronic inflammatory demyelinating polyneuropathy, because it is also associated with antibodies. That's why. And paraprotein neuropathy, a good example is multiple myeloma again. So plasma exchange and IVIG are usually given there. IVIG mainly works for GVS and CIDP, and plasma exchange works for all of them. Regarding the antimicrobial therapy, if leprosy is suspected, which are anti-leprotic drug you can prescribe? Can you name them? Which are those drugs? Yes, which are anti-leprotic drug? Anyone? So they are dapsone, rifampicin, and clofazimine. So let me write that. I'm not getting any answer. So probably you are confused here. So let me highlight them. Dapsone, okay, rifampicin, whatever you want to write, and clofazimine. So these are very important anti-leprotic drug. Don't forget. Okay. Now regarding the some other metabolic or systemic disease like diabetes, thyroid disorder, and kidney disorder, you diagnose them first and go for the specific management. Diabetes is treated by either insulin or oral hypoglycemic agent. It depends which type of diabetes you are dealing with there, whether it is type 1 or type 2. Thyroid disorder, especially hypothyroidism, is treated by thyroxine supplementation. And kidney disease, the chronic renal failure, is treated by dialysis, regular dialysis time and again. Chelating therapy, okay, like penicillamine is used for heavy metal neuropathy. Penicillamine. Okay, remember that. Can you tell me some other examples of chelating drug? Which other drugs are called chelating drug? Anybody? Which are other examples?
Desferoxamine.
Very good.
Desferoxamine.
Very good. Desferoxamine. Excellent. One more I want. Okay. EDTA. It is called EDTA. Okay. Ethylene diamine tetraacetic acid. EDTA. So penicillamine, desferoxamine, and EDTA. So these all are a different one. Vitamin B12. If we are dealing with vitamin B12 deficiency or subacute combined degeneration of the spinal cord, then you have to give vitamin B12 injection. Okay, that's quite an easy answer. Now, these are also very important one. These are called symptomatic therapy. Sometimes what happens, patient is having a lot of pain, a lot of burning sensation. Okay, so what we do, what symptomatic therapy we provide? Regarding the chronic pain disorder or chronic sensory problem disorder, like pain or paresthesia in the extremities, sharp and lancinating type of pain, we give this type of drug. Very important question in the exam, especially in the MCQ part. Gabapentin, carbamazepine, lamotrigine, or even sodium valproate. So these are the common drugs which are given there. Remember, these drugs are anti-epileptic drug, but they are not used for epilepsy purpose here, okay, or treatment of epilepsy purpose. They are used for the control of chronic type of pain. There is one good example I want to highlight here, known as trigeminal neuralgia. Okay, trigeminal neuralgia is a type of severe and chronic pain in the head and neck area because trigeminal nerve is there, and carbamazepine is one of the drug which we use there along with other one. In case of burning and deep pain, we can go for amitriptyline, desipramine, nortriptyline, or even opioid analgesic. Now this amitriptyline, desipramine, and nortriptyline belongs to which classification? What type of drugs are they?
Antidepressant, sir.
Antidepressant.
Exactly. They are antidepressant drug. Wonderful. But once again, they are not used here for the antidepressant effect. We can go for certain occupational therapy like brushing, okay, or physical therapy. These are just, according to the what deformity the patient is having. In some type of hereditary neuropathy, in some, badly affected neuropathy, then the muscles will be paralyzed, muscles will be weaker. There will be a lot of deformity development. So these therapies are done in that regard. Surgery is especially done in carpal tunnel syndrome. It's a very good example you can give here. And what surgery you want to do in carpal tunnel syndrome? What is the name of that surgery? Anyone?
Sir,
Decompression surgery.
we can divide the flexure retinaculum.
Very
By
good.
doing this, we can compress the nerve.
Exactly. It is known as decompressive surgery, and you need to cut that flexor retinaculum. Excellent answer. Yeah, that is the way you have to go for these type of treatments.